with patients having use of chronic myotic drops use such as pilocarpine for glaucoma, and in diabetes mellitus cases and previous history of uveitis in cases of uveitis with complicated cataracts, in pseudoexfoliation, in intraoperative floppy iris syndrome, in patients who are taking medicines for benign prostatic hyperplasia such as tamsulosin, terazosin, or dexazocin, and in cases of trauma to the iris, or in cases of neovascular glaucoma due to rubiosis iritis. So what are the challenges we face in phacoemulsification for small pupil is poor visualization, and sometimes due to small pupil inadequate capsular access or possible damage to the iris, and the placement of the in the bag IOL is difficult, and post-operatively increased risk of inflammation and cystoid macular edema. So to enlarge the pupil, we have sphincter sparing methods and sphincter involving methods. So sphincter sparing methods involves syneculisis, membranectomy, viscomydriasis, and involving the sphincter, we have iris retractors, stretch pupilloplasty, pupil ring expanders such as B-hex expanders or Malguin ring. And what are the principles of phacoemulsification in small pupil? That the low bottle height and low flow rate and should be there to minimize the turbulence in anterior chamber. And the rhexis is very important. The adequate size rhexis should be there. And the plane of emulsification, we should strike the balance in the plane of phacoemulsification. We should be a more anterior in the plane of phacoemulsification than a routine case, but we should strike the balance. So because if the plane is more anterior, we can risk the corneal, injure the corneal endothelium as well. And the judicious use of viscoelastic devices, and we should not overfill with viscoelastic devices. Underfilling is recommended. And use of pupillary expansion devices such as iris hooks, iris retractors, Malguin ring, and B-hex expanders make sense. So one video showing the technique for small pupil. This appropriate size rhexis is recommended, and we should, in the case of small pupil, we should go near the pupil margin so that the rhexis size is appropriate. Can I have volume in this? And the plane of the phacoemulsification should be a little anterior, and strike the balance, it should not be more anterior, and we should be always near the center of the pupil to avoid the complications. And the use of Helon 5 super cohesive viscoelastic device, and you should not overfill the device, and we should be always be in the phacoemulsification, and the chopper should be in the center of the pupil, and and in these cases, hydrodissection is also very important. Minimal fluid should be there for hydrodissection, so as to avoid the increase in the capsular back pressure. And the bottle height and the fluidic parameters should be low to avoid the turbulence in the anterior chamber. And after the in the bag IOL placement, proper removal of the viscoelastics by bimanual irrigation aspiration. And the use of the Malguin ring, it comes in two sizes, around 6.25 millimeter and 7 millimeter, and it has various scrolls. First, the distal scroll is placed, and sometimes while placing the distal scroll, both the lateral scrolls can be placed on the iris. And lastly, the proximal scroll is placed on the iris. And it gives a gentle and uniform enlargement of the pupil, and then we can now proceed for the capsular axis. Once the adequate size capsular axis is done, and the minimal hydrodissection with minimal fluid, then the phacoemulsification should be on the center, and the low parameters phaco, low bottle height and low flows to avoid the stress on the zonules as well. And after bimanual irrigation aspiration, we prefer hydroimplantation of the IOL. And the complete removal of the viscoelastics from the capsular bag. And now the malignant ring is being removed. Removed gently so as to avoid minimal damage to the iris. So there is no single one trick here. It is a multi-pronged approach for management of for phacoemulsification in small pupil as well as in IFIS cases. So iris retractors, pupil expansion rings, and high viscosity ophthalmic visco devices are available to facilitate this phacoemulsification in small pupil without any complications. And this multi-pronged approach which we follow, are pre-operative atropine drops 1% 2 times a day, 2 days prior to the surgery. And this incision, the main port and the side port incisions, the smaller incisions but with longer tunnel. So as to avoid the risk of iris prolapse from the incisions. And the dispersive OVD is better, but one should not overfill. And hydrodissection with minimal fluid so that the capsular bag pressure does not increase much. And low, as I said, low bottle height and low phaco-parameters. And if possible, one can use single-handed phacoemulsification and with the anterior plane of phacoemulsification. But sometimes in denser nucleus, single-handed phacoemulsification is not possible. And in OT, we can use solutions like epi-sugarcane, which contains epinephrine 0.025% and lidocaine, and intracameral lignocaine injection, and as well as phenocaine injections and adrenaline in the balanced salt solution. And there's a multi-pronged approach to manage the intraoperative floppy iris syndrome, preoperative atropine eye drops, smaller side ports with longer tunnel, as well as the main incision with longer tunnel, underfilling of the OVD, and minimal fluid during hydrodissection, and low parameter phaco, low bottle height, low pressure, whenever possible, single-handed technique of phacoemulsification, and to strike the balance in the plane of phacoemulsification to be in the center and as anterior as possible, not to be more anterior as to avoid the risk of corneal endothelial damage. Thank you.
Thank you very much.